she was referred for an ultrasound. And when I did the ultrasound, I saw a bulky uterus, and this was a per abdominal ultrasound, and the endometrium was somewhere between 6.7. On magnifying the image, I could see that the endometrium is extending till the myometrium in the lower segment. I decided to go in for a transvaginal scan, and on transvaginal scan, the endometrial cavity measured almost 8.8, but nothing much could be seen in the myometrium. So I decided to magnify the image, and here in the image here, what you can see is a hypoechoic area right at the level of isthmus with some anechoic debris within, also seen as few echogenic foci within that cavity. On transverse imaging of the uterus, few echogenic foci were seen along the myometrium, which consisted with the sutures. On further magnification, the hypoechoic cavity also contained those echogenic areas suggestive of the suture extending into that cavity. A detailed magnified image showed that cavity is continuing with the endometrial cavity, and here you can see the communication, and the depth of this cavity was almost 8.5. On putting probe pressure and per abdominal pressure, we could see a communication between the endometrial cavity and this anechoic area, and we could see the blood gushing out from this cavity into the endometrial cavity. No definite vascularity could be seen, but yes, definitely you could see that anechoic area had a lot, 3 or 4 sutures within it. The 3D ultrasound was attempted, and here you could see that there is a collection within the endometrial cavity extending into the myometrium. So we came to the diagnosis of isthmocele. Now, what is this? The definition of isthmocele is a defect located in the inner wall of the caesarean scar area, and it generally measures between 1 to 2 millimeters deep. And if or the depth of the isthmocele is more than 50% of the myometrium, it is considered a severe type of isthmocele. So the patient generally does not have any. Mostly when we see isthmocele, it is asymptomatic. But the patient, if at all symptomatic, presents with abnormal uterine bleeding, which could be dark red or brownish, and is generally post-menstrual. It can be associated with dyspareunia, chronic pelvic pain, dysmenorrhea, secondary infertility, ectopic pregnancy, uterine ruptures, and placental anomalies like placenta accreta. The predisposing factors are caesarean section after cervical effacement, incomplete repair or hysterectomy. Contributing factors may consist of suture type, closure of the uterine closure with locking sutures or a single layer can also predispose to isthmus formation. Low caesarean incision position again is a predisposing factor. Non-repair of peritoneum, additional hemostatic sutures are needed, endometritis and anterior wall adhesions are additional predisposing factors. 24 to 70% isthmoceles can be diagnosed by transvaginal ultrasound. However, sonohysterosalpingography has got more accuracy of almost 84%. In more than 50% of the patients with history of caesarean section, isthmocele can be observed when examined by saline hysterosalpingography between 6 to 12 weeks after the caesarean section. So to conclude, dysfunctional or abnormal uterine bleeding and post-menstrual bleeding in a post-LSCS can be due to isthmocele and needs high degree of suspicion and a transvaginal scan for diagnosis. Thanks.